Hello, my name is Dr. Jess Orn, a cardiac electrophysiologist at Geisinger. I would like to spend a few minutes discussing the management of atrial fibrillation in the primary care setting. Atrial fibrillation is characterized by chaotic atrial activity that results in an irregular and often rapid ventricular response. An EKG is needed to confirm the diagnosis of atrial fibrillation and can help differentiate from other conditions like atrial flutter, multifocal atrial tachycardia, regular SVT, and sinus rhythm with premature atrial contractions. Patients may be asymptomatic or experience fatigue, shortness of breath, and palpitations. Complications of atrial fibrillation include tachycardia-induced cardiomyopathy, enlargement of the atria, and increased risk of stroke from stagnation of blood within the left atrial appendage. It is important to identify potential correctable causes of atrial fibrillation like hypertension, obesity, ischemia, sleep apnea, hyperthyroidism, and excess alcohol use. An echocardiogram is recommended to diagnose structural disease such as left ventricular dysfunction and valvular heart disease, which may be a contributing factor. There are several treatment strategies that should be considered. Rate control can be considered for older asymptomatic patients. On the other hand, rhythm control to maintain normal sinus rhythm should be considered for younger symptomatic patients. Anticoagulation therapy is equally important and is necessary to prevent thromboembolism. Emergency department care is only needed for hemodynamic instability. Most patients can be managed in the office, but for blood pressure of less than 100 millimeters of mercury with symptoms, regardless of heart rate, the emergency department is the right place for care. On the other hand, if the blood pressure is greater than 100 millimeters of mercury and the heart rate is less than 120 beats per minute, patients can be managed in the primary care setting. Rate control can be achieved by ordering beta-blocking agents like Metoprolol or Diltiazem. Anticoagulation, either with warfarin or direct oral anticoagulation as an outpatient, can be ordered. If the heart rate is between 120 and 150 beats per minute, either the PCP office or same-day access in the cardiology clinic could be sought. For a heart rate of greater than 150 beats per minute, it makes sense to send the patient to the emergency department. Inpatient admissions should be reserved for precipitating or concomitant cardiac event such as an acute myocardial infarction, pulmonary emboli, new onset of congestive heart failure, or other severe events. Patients are often admitted to initiate antiarrhythmic drug therapy at the advice of the consulting cardiologist or electrophysiologist. Here are some pearls to be considered in the management of atrial fibrillation. Number one, stroke risk with non-valvular atrial fibrillation or atrial flutter is determined by the CHADS-VAS scoring system. The CHADS-VAS score is most commonly utilized method to predict thromboembolic risk in atrial fibrillation. Risk factors included in this scoring system include congestive heart failure, hypertension, age, diabetes, stroke, peripheral vascular disease, previous myocardial infarction, aortic atheroma, and gender. Each risk factor receives 1 point except for age greater than 75 and stroke, each of which receive 2 points. Number two, long-term anticoagulation is indicated for patients with a CHADS-VAS score equal to 2, whether their atrial fibrillation is paroxysmal or persistent. Number three, aspirin or the combination of aspirin plus clopidogrel does not offer the same protection against stroke as does warfarin or a direct oral anticoagulant such as rivaroxaban and apixaban. Number four, patients with atrial fibrillation and hypertrophic cardiomyopathy, mitral stenosis, or a mechanical valve should be treated with warfarin only. A rate control strategy is reasonable in many patients with atrial fibrillation, especially those who are elderly and asymptomatic. Rate control is employed to improve symptoms and avoid tachycardia-induced cardiomyopathy. Adequate rate control is defined as an average heart rate on a Holter of less than 100 beats per minute or a maximum heart rate of less than 110 beats per minute during moderate exercise. AV nodal blocking drugs include beta-blocking agents and calcium channel blockers. Metoprolol tartrate at doses of 25 to 50 milligrams twice daily, or metoprolol succinate at doses of 50 to 100 milligrams daily can be used, as well as non-dihydropyridine calcium channel blockers, such as diltiazem CD at doses of 120 to 240 milligrams daily. Digoxin is a second-line agent that can be used to control the ventricular response. Rhythm control is best for symptomatic atrial fibrillation, especially in younger patients, to decrease the frequency and duration of atrial fibrillation events and improve symptoms. The choice of antiarrhythmic drug therapy is based on the presence or absence of structural heart disease, heart failure, hypertension, and underlying renal and hepatic function. Direct current cardioversion is often necessary to restore normal sinus rhythm, with an antiarrhythmic drug on board to maintain normal sinus rhythm. Antiarrhythmic drug therapy is often initiated as an inpatient due to their potential proarrhythmic effects. In non-pharmacologic rhythm management, radiofrequency catheter ablation is reserved for persistent symptoms, younger patients, and patients who fail rate or rhythm control. Catheter ablation is useful for patients with symptomatic paroxysmal atrial fibrillation who prefer an ablation over long-term antiarrhythmic drug therapy, or who fail or are intolerant of at least one Class 1 or Class 3 antiarrhythmic drug. A repeat procedure is sometimes necessary. The need for long-term anticoagulation following successful ablation is determined by the CHADS-VAS score and not the success or failure of the procedure. Patients started on warfarin therapy require close follow-up, with target INR for most AFib patients of between 2.0 and 3.0. Patients may be referred via EPIC referral 278. Please contact the Danville Anticoagulation Clinic at 570-271-5594 with any questions or concerns. We owe it to our patients to keep them healthier and manage their atrial fibrillation more effectively. Thank you.